by the fact that they are in more vulnerable communities. There is often a reluctance to engage in anything that involves seeking out the government, and so that makes them reluctant, even when there are policies in place, to go and get covered, go access health care for themselves and their kids. And there is also missing in many immigrant communities literally a physical infrastructure of health care. So let me give you an example of the Texas Valley. The Rio Grande Valley in Texas, one of the fastest growing areas in the country, and home to about 1.5 million people, about 90% Latino. And it is a place in Texas and in the United States where there is still no major medical center, where you still can't get a medical degree anywhere south of my hometown of San Antonio. You can drive 4 hours to the Texas-Mexico border, but can't get a medical degree. And that will not be the case until about 2016 or 2017. So literally, pieces of infrastructure, of opportunity missing in these communities. And as we think about how we're going to change that, certainly all of us need to make a push, I believe, to get people enrolled in the exchanges as they're set up, as the Affordable Care Act is rolled out. I know that through my office and many other congressional offices, including Michelle Lujan Grisham and Ben Ray Lujan, we're going to make a strong push to have as many people enrolled in those exchanges as possible. But inevitably, for many of the reasons that I described and some that I've not gotten to, there are going to be people who fall through the cracks. Many of those people will be immigrant families, and we can't forget about them. We cannot give up on those who are vulnerable and those who always seem to fall through the cracks. And I look forward to the discussion today in trying to find ways to do better by them. Thank you very much.
Oh no, that was Congressman Castro. You missed me. Oh, like the whole slide. Anyway, so I'm Leighton Koo. I'm speaking here. And let me first of all say I want to, it's what an honor it is to be introduced by Congressman Castro. Actually, I grew up in San Antonio, Texas. Yeah. So I'm proud to see someone representing San Antonio in such a great way and doing such great things in Washington and trying to bring progressive policies. So I want to start it off from a national perspective. And all today we've been hearing about the complex problems of the social, cultural, economic, and other challenges that face disparities. And one of the things that's important to remember about immigrants is also legal status comes in. And in fact, effectively speaking, it is legal to discriminate against immigrants, and we do discriminate against immigrants in many different ways. Mm-hmm. And it's not a simple dichotomy of are you documented or are you not documented. In point of fact, there are many different grades, and so this makes the policies even more complicated. So I'm not going to go through all the listings of the statuses here, but simply to mention that there are many statuses. This makes knowing and understanding the rights that immigrants have vary so much. For adults, there are many grades that go between naturalized citizens all the way through legal, lawful permanent status, people who have various temporary statuses, and finally the undocumented. Certainly if you listen to a lot of the publicity, a lot of the talk, in many cases you think all immigrants are undocumented, and of course we know that's not true, though a large number are. On children, the great majority of children in immigrant families are US born, are citizens inherently, though their parents are immigrants. They have the whole range of legal statuses. One of the newest legal statuses was created by the Obama administration, the Deferred Action for Childhood Arrival status, which provides some temporary legal status for, I group them as kids, though actually they go between the ages of 15 to 30. I'm old enough, so a 30-year-old seems like a kid. So anyway, so you know they range that whole road. Because I'm a researcher, I like numbers. I just want to indicate very quickly, we do know very clearly that immigrants have very severe gaps in insurance coverage. So what you have here, I'm going to show a couple of slides that deal with immigrant children. In fact, the statistics for adults are even more grim, but I'm going to skip them just for the sake of brevity. The point in this slide is if you look, we're looking at 3 different types of children, all low-income children. So citizen children with citizen parents, basically speaking, US-born children and their parents are native-born, they have relatively low levels of uninsurance. However, higher up are citizen children whose parents are immigrants. So though they are citizens, they still have somewhat higher levels of uninsurance. And then the highest levels yet are the children who are not citizens themselves. And so you see this very steep gradation. Now, one of the things that many people know is that there are some bars and some barriers for non-citizen children in terms of getting Medicaid coverage and public coverage. What I think many people don't realize is that there are also some fairly serious gaps in private insurance, and that private insurance gaps occur for both the citizen children as well as the non-citizen children. So this is something that's happening to immigrant families regardless of whether their children are US born or not. Similarly, because of this, we see that there are fairly large gaps in access to care. So this is a fairly simple measure. Did you see a doctor in the last year? So most children who are native born, 67, 69%, do see a doctor. Children are normally pretty healthy, so they don't all need to see doctors constantly. We see the levels are much lower for immigrant children, and we see the levels are particularly low for both native and immigrant children who are uninsured. So this is one of the reasons why we care so much about getting insurance coverage expanded through the Affordable Care Act and other measures. But you look at those who have private insurance and those who have public insurance, you still see some gaps for the immigrant kids. So we know from a lot of research, a lot of experience, that there are lots of reasons for these gaps. So some of the gaps are, once again, I think it's important, people often don't realize there are private insurance gaps. Immigrant families often have less accessibility to private insurance. They're less likely to be offered health insurance on their jobs. And because of it, they and their children can't get that work. There are some bars that were set into law on limits on Medicaid and CHIP coverage for legal immigrants. And obviously those who are unauthorized can't get access to Medicaid at all. We realize there are the usual problems. Immigrants tend to be poor on average. They tend to have language and cultural barriers that also limit access. And then, as has often been mentioned, there is often fear of repercussion of trying to access benefits, particularly of their public benefits. So even though there are places where undocumented immigrants can get access to care, in many cases they're hesitant about doing it because of the concern of exposure and the possibility of deportation. Now, the Affordable Care Act, or Obamacare, is making some important changes. And so under this, low and moderate income immigrants should be able to get access under the health insurance exchanges if they're legal immigrants. They'll get subsidies to help them cover. Now this is important because this will help fill that gap in private health insurance coverage. So this is a critical step. If the immigrant family can't get access to coverage through their workplaces, this is a place where they can get it. Now obviously the Medicaid expansions will also help legal immigrants. On the other hand, we do certainly know that in a number of states, about half the states, once again, my home state of Texas is one of them, they're not expanding Medicaid, so that's going to be a real problem for them. Sadly, unauthorized and immigrants in general and the DACA kids are not going to be eligible for the health insurance exchanges or for Medicaid. We also know that immigration status is going to be screened by DHS when people try to apply for the exchanges, and this may deter some people. Again, even though it won't be negative action necessarily against them, the screening in and of itself can cause some concerns. And once again, a lot of the states aren't expanding Medicaid. The final thing I want to talk about is immigration reform. This was certainly one of the big things that came out over the past year, was the effort to have comprehensive immigration reform. And it's worth understanding what happened and how mammoth it was that the Senate passed a comprehensive immigration reform bill on a bipartisan basis. And one of the principal things that so many people have talked about is setting up a pathway for for undocumented immigrants to get legal status eventually as registered provisional immigrants. It is a long pathway, a 10 to 13-year pathway. On the other hand, it was a bipartisan vote. Now, one of the compromises that happens in these things is that there was, basically speaking, the primary fights in this bill centered on three issues. And there were three big goals. One was the path to citizenship, and certainly that mattered a lot to the immigrant advocates in the Hispanic community and the Asian community. Second, there was a broader interest in an increase in legal immigration, partly for economic reasons, and partly because of the backlog of millions of people who should have been admitted, have permission to come into the country, but for various technical reasons have not been able to enter yet. And then finally, there was the countervailing force of concerns about stronger border security. So those three elements had to be balanced in creating the immigration reform bill. It's unfortunate to say that health insurance expansions were not in that priority. They were off the table from the start, and it was a bipartisan agreement that they were off the table. And they were off the table for two reasons. One, it would have increased the cost of the bill a lot to expand benefits for immigrants. The second was, frankly, Obamacare has just been so damn controversial that to get anything bipartisan that involved Obamacare would have been suicidal. So this was a problem. And it came out as the nature of the compromise. Nonetheless, the bill will still help immigrants, and in fact, probably represents one of the most important civil rights actions for a long time. On the other hand, heightened border security will cause some problems. The challenge now is we don't know what's going to happen in the House of Representatives, or I'm sad to say we're afraid we do know what's not going to happen. I'd certainly hope that Congressman Castro and some of the others can help make sure that there's some forward progress, optimally this year, if not this year, next year, on actually trying to have an immigration reform bill that can pass. Thanks.
Thank you, Dr. Koo, for setting the stage so well. And thank you, Lisa, for inviting me to be a participant on this auspicious panel. I'm here today to talk about federal support for immigrant health care coverage and to remind us that prior to the ACA, there have been some federal policy tools to expand coverage for some subsets of low-income immigrants, both undocumented and legal. These programs have not been comprehensive, they've been piecemeal, they've been incremental, state-by-state efforts, but I will argue that they've been reasonably effective and they are something to build on for the future. And especially given the 2012 Supreme Court ACA decision, state-by-state incremental policies represent one of the most important ways we have to expand public options for coverage. I'll talk today specifically about prenatal care for undocumented immigrant women. This is a program I know well from my years of working in healthcare in Washington State. Did I mention I'm from Washington State? Washington State, where it's 60 degrees today. And from my own research as a training political scientist. But I'll also talk about how I think similar policy options can be used to expand coverage beyond prenatal care. So the S-CHIP unborn child option allows states to opt in and provide coverage for prenatal care for low-income undocumented women under their S-CHIP state plan. The federal program started in 2002 as an HHS regulation. Before this, a number of states did provide this coverage and these services with state-only money, but we know that state-only programs are very vulnerable to cuts during times of economic downturn, and there was little stability in those programs. The unborn child option, importantly, allows states to access their S-CHIP matching rate, generally much higher than their Medicaid matching rate, and to provide coverage. So in this way, the federal funding and the federal-state partnership provide an important stability to these programs. In 2009, this policy option was codified in federal law with the 2009 S-CHIP reauthorization. Currently, 13 states provide coverage for undocumented immigrant women under this option. And you see the list there. This includes important states that are large immigrant receiving states like California, Illinois, and Texas. In addition, New York provides this coverage and care through an alternative federal state funding matching mechanism that they've had access to since the 1980s. So from a political science perspective, those of us who study variation in state policy adoption, we know that there are a variety of state characteristics that contribute to policy adoption decisions at the state level. We generally think of these characteristics in four broad buckets. There are economic characteristics, program need characteristics, and political and demographic characteristics. Variation in all of these areas can often explain why some states adopt certain policies and other states don't. When we look at the differences between those 14 states that have adopted this policy, and I include New York in that group, and the 36 that have not, we see definite differences. I won't bore you with the research and the statistical significance, but I'll say that there are significant differences in all four of those characteristics, all four of those areas of characteristics between adopting states and non-adopting states. And I'll point you to those that I think are most significant for our story today, in the area of program need, we see definite differences. In the adopting states, over 22% of the births in those states are to foreign-born women, versus the non-adopting states, only about 15%. And if we look at the ratio of the undocumented population to the total population, it's about 8% in adopting states and only about 3% in non-adopting states. So the adopting states definitely have higher need. And the important point here is that it's in part because of these differences and because of how these differences drive policy adoption at the state level that we can find some level of program effectiveness, even though only a small minority of states have opted into this policy. By effectiveness, I mean first that the program has reached the intended target population. Even though only 14 states have opted into this federal policy, those 14 states are home to a majority of the total estimated undocumented population in the country. Almost 57% of the total undocumented population resides in these 14 states. Similarly, these states are where over 60% of the births to foreign-born women are happening. Finally, researchers have provided evidence that this coverage and these services are taken up by the undocumented women they are intended to reach, so that women can benefit from the reductions in morbidity and mortality that we know accrue from prenatal care. So although only a small minority of states have taken up this option, because those states are not the same, and in fact because those differences drive the differential take-up rate, this program has been reasonably effective in expanding prenatal care and almost certainly has improved health outcomes because of that. But what about coverage beyond prenatal care? Are there indications that there may be public support, maybe even voter support, to expand this kind of coverage beyond prenatal care to other subgroups of undocumented immigrants? I believe there is. First, I'll point again to the 2009 CHIP reauthorization, in which Congress included the Immigrant Children's Health Improvement Act. Thank you to members of Congress who supported that. This act restored the option for states to cover legal immigrant children who had been in the country less than 5 years. We often speak of the 5-year bar. Well, this act removed that for legal immigrant children who live in low-income families in order to access SCHIP. To date, 23 states have taken up this option. Second, I'll point to a study recently published by a research team here from our own Center for Health Policy here at UNM. Professor Sanchez and Shannon Sanchez-Youngman analyzed a 2008 survey of New Mexico voters and asked them about support for expanding government-funded health care to undocumented immigrants. While only a minority supported expanding such coverage to undocumented adults, a majority, 52% of those voters surveyed, supported including undocumented children. Now, this survey was limited to New Mexico, but the authors make a good argument why the findings may be generalizable beyond New Mexico. And finally, I'll point to a 2013 Latino Decision Survey just released a couple of weeks ago, in which Latino voters nationally were asked about this topic, and 62% of them think that undocumented immigrants should be eligible to participate in the ACA exchanges and benefits. So for those elected officials concerned about the ever-increasing Latino vote, that may be important. I'll just conclude by saying that state-by-state expansion of coverage using existing policy tools has been reasonably effective in expanding care and coverage for low-income, undocumented immigrant women who are pregnant. This effort's been successful in spite of the fact that only a small minority of states have taken up this policy option. And in addition, there do appear to be indications that the opportunity exists to expand coverage to low-income, undocumented children in a similar state-by-state way. Thank you.
Hi, I'm John Capitman. There's just so much to be grateful for today, but one of the things I wanted to mention was the wonderful work of the sign language interpreters. That's just been such a treat. Thank you. And I came to speak a little bit about healthcare access for immigrant children in the San Joaquin Valley counties of California. These 8 counties share so much in terms of history and current economic structure to this region, to New Mexico, that I think some of the comparisons may be interesting. I'm going to say my 3 takeaway messages first because I'm going to get cut back before I finish. So 3 things I hope you hear from me. First, even though we're all incredibly excited by the opportunity afforded by the Affordable Care Act to get lots of people insured, lots more people insured, it's very important to remember some of the other goals of the Affordable Care Act, including increasing prevention efforts and looking at ways to develop communities that are supportive of health. And what we see in the data for our region, and I think you see in the data for your region, is that the characteristics of communities, your zip code, continues to be a huge determinant of health outcomes. And so in our excitement about affordable care and our excitement about insurance, I hope we won't lose track of those other issues about the social determinants of health inequalities. Second thing I want to point out is that even in the context of these great state and national policies, enormous power still rests with local government, with counties and with regions and with cities to shape healthcare access, and particularly for immigrant communities. And so I think it's important to keep talking about the local. In saying that, I'm so reminded that I'm building on the work that Lisa Carcari-Stone did almost 10 years ago in New Mexico. And so in a lot of ways, one learns from one's students, and that's the work that I'm excited to be part of. And then my third little point is that, and it's a big point, is that healthcare access is also determined by the behavior of healthcare systems. And in our region, at least, we find that culturally disrespectful care, language incompetent care, are reported by people as a major barrier to seeking healthcare, a major barrier to seeking healthcare insurance. Those are my 3 points. The San Joaquin Valley has 8 counties, has a population of 3.5 million. It produces about 40% of the fresh fruits and vegetables in the United States. It is one of the 4 poorest regions of the United States. And while agricultural profits have risen every year for the last 20 years, agricultural workers and other workers at the bottom of the food system continue to receive incomes that are very similar to the 1960s. So there's been no real massive improvement in people's access to decent jobs. We have higher mortality and morbidity than other places in California and the nation, complicated patterns of cause-specific mortality that are linked to race, ethnicity, to immigration status, and to economic well-being, and huge differences across communities in mortality that seem to be linked to neighborhood demographics, exposures, and resources. So in this map, I show variations in premature mortality across the 8 county regions. The darker colors represent higher rates of premature mortality, the lighter colors less. There are, for example, in Fresno, a 25-year difference in life expectancy between communities that are 10 miles apart. These are bigger differences between the United States and Guam, for example, or between Japan and any number of countries in the world. So these are huge differences in life expectancy and extremely high rates of premature mortality. The communities associated with high rates of premature mortality have much higher percentages of low-income people, higher percentages of immigrants, and tend to be more racially segregated. But there's an emerging consensus that there's more than demographics going on. A consistent and growing literature in our region demonstrates that the same communities that have these high rates of premature mortality also have among the worst air and water quality, lack access to transportation, have housing shortages, housing quality issues, lack consistent programs of economic development, have educational systems that are relatively underfunded and relatively less successful, and have human service access variations that are even more dramatic than the healthcare service variations. These health inequalities are explained by historical forces and current policies that concentrate low-income people, people of color, and recent immigrants in urban and rural communities that lack the basic resources, the fundamental supports for health and well-being. I think Congressman Castro's concept of the infrastructure of oppression is exactly what we're talking about, the infrastructure of opportunity. Regional and local policies haven't focused on these issues. And in fact, current debates reflect a dramatic disconnect between the ag sector and its huge political power and the rest of the concerns of the communities. So in this context, by the way, I think we see an important explanation for the so-called Latino paradox with respect to health. These communities create environments of trauma. Feliti's work on a growing body of literature shows that childhood exposure to trauma is a major predictor of lifetime negative health outcomes. And so we have communities where people regularly expect to see family members deported, family members killed, family members who can't get health care, family members whose mental health problems go untreated, housing insecurity, and the list goes on. The traumas that the youth express to us in the context of a number of programs that we've been evaluating are, leave me speechless. So that's the context in which we're going to talk about healthcare access. So in California, almost 92% of Latino children were U.S. born, 78% of Asian children. In the Valley, it's a higher percentage of Latino children, about 18%, and a lower percentage of Asian children who are not U.S. born. And I focus on that because of the importance, as Leighton has pointed out, of birth in the U.S. In terms of access to health care and insurance. This next slide shows that for Latino children, more than half, 55%, have a non-U.S. born mother. And among Asian children, 90% or more have a non-U.S. born mother. We don't have data on the fathers, but if you combine the fathers, I think that would imply even higher rates among both of these communities of children who are in families where the parents may have very difficult access to health care, even if they themselves are U.S. citizens, even if the children are U.S. citizens. Statewide in California, about 28%, and in the Valley, about 35% of the population are so-called undocumented. In the Valley, it's estimated some 300,000 people are both undocumented and uninsured and will remain uninsured as Obamacare is implemented in the region. Despite big efforts to reach out to other immigrant communities, the documented immigrant communities, our strategies are bound to be of less than desirable success. Estimated 49,000 children in the Valley, 17% of those with mothers born outside the U.S. were uninsured in 2009. That's 3 times the rate of uninsurance among children with U.S. born parents. Healthcare choices are family decisions, it's well known. Families that see themselves as excluded from the healthcare system are going to have a harder time understanding how to get enrolled. We're going to have a harder time even knowing that enrollment is possible. At least 1/3 of Valley children are in households with one or more undocumented. Unfortunately, the care that's going to be available, the options that are going to be available to undocumented persons in the Valley in terms of health care are the decisions of the counties. The counties, of the 8 counties, 4 provide some coverage for undocumented people, 4 do not. Even those counties that provide coverage tend to restrict it to emergency services. The 2 largest counties, Fresno and Kern, have limited access to specialty services for undocumented persons who do become eligible for their local indigent care. However, with the implementation of the Affordable Care Act, California is going to take the funding that it had been providing to the counties to support care for undocumented and indigent populations, and take that back to use that to fund Medi-Cal expansion. The effect of that is that the indigent care funding to the counties will be reduced. Counties use those funds for both undocumented person services and also for population health services. And each of them has already signaled an unwillingness to expand local contribution to health care or to public health in the context of these reductions. This is just an emerging battle, but it continues an ongoing process of local legislative decisions, local policy decisions being made on the basis of the best needs of the agricultural community instead of on the best needs, the responding to the needs of communities of color and undocumented folks. One more set of areas really needs to be taken into account. We've done several studies in our region about how people access the healthcare system and their experiences. Our 2011 survey of Hmong in the Valley found that culturally disrespectful care experiences and the expectation of culturally disrespectful care led to less interest in changing their insurance status and less use of primary care. Our 2010 qualitative interviews with 415 Latino mothers, a quarter of whom were undocumented, found that experiences and expectations of malos tratos, of the same kind of inappropriate, disrespectful care, predicted insurance seeking, predicted enrollment, even with assistance from a promotora, and it predicted appropriate use of services once enrolled. So people who had bad experiences of being treated disrespectfully in the healthcare system are going to have trouble enrolling. This is a challenge that we really need to talk about more specifically. And finally, a recent survey of child health insurance expansion efforts in the Valley found that lack of information on how to use benefits and lack of language and cultural appropriate care limited the use of the coverage. I think the implications are clear. I'm drawing out the end of my time, but we have to consider how to expand the Affordable Care Act to include all undocumented populations. We need to make sure that the community development and public health elements of the Affordable Care Act are funded, are implemented, and that the new proposals, such as the Promised Neighborhoods being floated by the administration, get taken seriously and are really addressed as a way to address the social determinants of health. Immigration reform needs to talk about how we can how we can separate that pathway to full citizenship from access to health care if we don't want full citizens who have been left for 13 years without access to care. And then finally, we need to continue to put a real investment in how do we create more practitioners of color and how do we increase the cultural competence of healthcare systems. Thank you.
Good afternoon. I'm Veronica Garcia. I want to thank the Robert Wood Johnson Foundation, the Center for Health Policy here at UNM for hosting this. And thank you to Congresswoman Michelle Lujan Grisham, who is still here with us, and Congressman Castro. Thank you so much for being here this afternoon and for inviting me to speak to you. Having been a school marm most of my life, I can sense that look, and you have that look on your face, okay? You remember Charlie Brown? And when the teacher talked, and it was like, wah, 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 and the kids are just sitting there like, good grief. So I see little bubbles above your head that say, you know, I'm playing Word with friends, I'm killing angry birds, and assorted fantasies, I see them above your heads. And I know that I am standing between you and a margarita or a glass of wine. So the main thing that I'm going to tell you, I'm going to go over a few key factors or just points about New Mexico, and then hit the policy recommendations. The first thing I want to start off with, though, is, oh, that's not mine. Okay. By the way, I almost took his cell phone because I thought he had the pointer, and he's like, no, it's my phone. I was like, give it to me. All right, sorry about that, doctor. Anyway, just a little aside. I know I'm trying to...
I thought you wanted the timer.
Well, no, I wanted this, and I thought you weren't giving it to me. Anyway, I think many of you have heard, unless you have been in really, really deep sleep, that New Mexico ranked 50th in child well-being. And it's interesting. We were going along just fine when we were 49. But man, we hit 50th and we have a crisis. It's like we had a crisis when we were 49. Okay, but at least we got folks' attention, right? And 2 of the 4 domains are around education and health. And I do not feel, as a longtime educator, that you can separate health and education. Because if children are not feeling well, they're not going to be doing well in school. And if we want to build New Mexico's economy, what are the drivers of economy? It's not tax cuts to corporations. Applause, please. Thank you. Thank you. It's investment in education and health. So we're 50th at child well-being. Guess what we're number 1 in, among other things? Income inequality. So if we're 50th in child well-being and we're number 1 in income inequality, who's doing the worst in all of this? Immigrant families. So the worst of the worst, being hit the hardest, immigrant families in our state. And so if you think of one thing, I know that we're preaching to the choir here. So I think the idea is that you'll go out and talk to people about doing their best to promote the policies that are going to make the most difference to improve New Mexico, the state that we all care and love so much. So if we can't motivate them from doing the right thing, we have to motivate them from their pocketbook, about the economy, or just basically, we all do better when we all do better. And so if they're not motivated about what's right for their fellow man, then in their own self-interest, it is in their interest to take care of the poorest of the poor, to take care of the most disenfranchised, and to take care of immigrant families. So here's my first slide, and we will whip through these because I know that Margarita is calling you. Even though New Mexico is a border state, our immigrant population is fairly small. It's about 10%. Our population of undocumented immigrants is also small due to lack of jobs, and well-paying jobs for sure, right? We do not have a large population of immigrant children, and I was really surprised about that, 4% of all New Mexico children. However, a large contingent of New Mexico children, 1/5, live in immigrant families. And so I was asking my staff, what? Well, they're born to immigrant families. So while this percentage of children is so small because their parents are immigrants, what happens? Then their families do not seek the kinds of services that their children are eligible for due to fear and all the things that you know are impediments. Most children living in immigrant families, 85%, are U.S. citizens. 55% of children in immigrant families have parents who are not citizens. So that's back to what I just talked about earlier. While children born in the United States are eligible for Medicaid, their parents are less likely to enroll them if they are not citizens. Again, fear. But even if you are a citizen, I've been dealing with HSD because of my mother. Have you ever tried to deal with any of the forms or the letters or the things they sent you? I finished my dissertation. That was a task. Trying to read the letters that you get from HSD, I can't. I don't know who wrote them or why they write them the way they do, but it's like, what are they saying in this letter? I asked 4 or 5 people, read this. Does this make any sense to you? And so if you don't understand the system, and even though your children are eligible, do you think you're going to call and try calling. That's a whole other thing. But if you could get through to somebody, it would be a really scary experience. Immigrants in New Mexico are far more likely than native-born New Mexicans to lack health insurance, just as it is in California or the rest of the country. Only 17% of native-born New Mexicans lack health insurance compared to 48% of foreign-born New Mexicans. And immigrant New Mexicans are more likely to work at low-wage jobs than native-born New Mexicans. So again, the poorest of the poor is the heaviest hit. And all of the pieces that go with that lack of access to health care. So let's get to some policy recommendations. And there's one that is missing. And Congresswoman, I was sitting there and I was thinking, what did we work on together a lot? School-based health clinics. And that really should have been my #1 recommendation. Thank you. Access, school-based health care. I think that, if we're going to do something in New Mexico, we want to argue, immigrant status and, all of these issues. If we could get, and for many of our children, that's the only place, especially in a very rural state like New Mexico, that they have access to health care. And so school-based health services probably should have been my #1 up here. And I think it was so obvious that I missed it. So as you talk to people, that's very important. And so as you talk to your legislators here in our state, let's push for that. Secondly, immigration reform that draws all immigrants into the healthcare system. No brainer. You've been hearing that. Thank you. You made my day. So improving immigrant health status, improve worker productivity, lowers health costs for everyone. It's a no-brainer. It's a way for New Mexico to pull itself out of that number 50. More children being enrolled in having health insurance was one of the indicators that caused New Mexico for that 50th ranking. 2, until then, we should improve enrollment of citizen children and immigrant families by increasing outreach efforts so immigrant parents know about Medicaid and know that their children are eligible. You know, New Mexico did accept the money. I've got to stop. But it's almost like New Mexico's best kept secret because people don't know how to access it. They don't know anything about it. So we need to improve on that. And lastly, increase incentives for providers to work in rural areas. We have many underserved in the rural part of the state. The hook is coming out for me. You've been wonderful. I'll see you at the reception. And remember, when we all do better, we all do better. Thank you.
Good morning, good afternoon. So before Congressman Castro leaves, I want to just say one thing quickly. Just drawing from the promotoras that I worked with on this particular study, mandan muchos saludos a usted y su mamá. So thank you for being here. So today, I'm from Arizona, and I didn't see any hands go up for Arizona. None, no one. Okay. Well, we're doing quite a job in Arizona, especially related to these issues. We have people actually on the ground right now trying to repeal Medicaid expansion in our state. They're knocking on doors as we speak. So today I wanted to just quickly, because I know we're fast, my role on this panel, I think, is to bring stories of immigrant families that live on the border and the ideas that are happening related to the militarization of our border and the issue of border security. And so when we listen to the rhetoric related to immigration reform, I want you, I guess I'm going to do the same thing John did and tell you my 3 messages first, is when you hear immigration reform and you hear border security, I want you to reframe that issue as a public health issue. Increased border security is a public health issue. Grijalva right now is in Nogales, out of our largest port of entry in Arizona, talking and trying to reframe this issue as not only immigration reform, border security issues as an economic issue, but also a humanitarian issue. Apart from the things that I will talk to you about today, mistreatment, there are approximately 250 people die in our desert every year. It's like a plane crashing in our desert. People trying to cross and actually not making it and dying in our desert. So border security is a humanitarian issue on several fronts. So I'll tell you those 2 things. So reframing. So I'm thinking about mistreatment, immigration-related mistreatment among permanent resident and U.S. citizen Mexican origin, Mexican descent people. And so these are stories of people that are living on the border, and I was going to transport you to a place. In fact, I need to go forward once. I need to transport you to a place. In our state, we have done an amazing job at restricting and passing legislation that restrict access to education, to health services, to safety issues in the job. It's pretty incredible. Our state is really just it's shocking what we're doing. And the other aspect of what's happening in our region is the border is becoming more and more militarized. And so imagine that you live in a community where Border Patrol are everywhere. They're in your supermarkets, they're in your neighborhood, they're everywhere. And you are trying to go about your daily life. And so we think about this as a form of everyday violence where you're constantly under this stress and interaction with Department of Homeland Security. So these are just some of the pictures that are happening. So we did a study with community, with 300 people from the U.S.-Mexico border, all Mexican. 90% of them are U.S. citizens, permanent residents, and already living a very structurally vulnerable situation, as you can see, with many people making far less money than they can survive on. And what we found is we were trying to assess the prevalence of immigration-related mistreatment among this population. Because we hear about immigration-related mistreatment among undocumented people, but what we're finding is that this idea of conflating ethnicity with immigration status is just absolutely incredible, especially among immigration officials and local law enforcement that are now uptaking a lot of the immigration roles and acting and with authority of the federal government. And so we found that 90% of families are seeing immigration every day, 90% every day, daily sightings of them. But what's so incredible is it's not at a U.S. port of entry. The majority, 75% of these sightings and these encounters with immigration officials are actually in the community. And you can kind of see neighborhoods, 90% immigration officials in your neighborhood, on bicycles, in trucks, on horses, at your work site. 60% are at the work site. We tried to look at how immigration-related mistreatment looked across the different types of mistreatment. So we looked at verbal mistreatment, we looked at physical and emotional and racial ethnic perceptions of being profiled because of your ethnicity or race. And what we found was they were more than 1/3 of people actually reported having this experience, having an encounter with officials. And what we've tried to look at is, okay, well, what does this do to someone's stress? And we know that stress is a horrible marinade. Absolutely, the cortisol that is produced in our bodies destroys our organs, and this is this constant fight or flight reaction that is occurring. And so what we found were that people that experience any type of interaction with a Border Patrol agent were twice as likely to experience high levels of stress. We found that witnessing stress witnessing immigration encounters, negative immigration encounters, actually they were 3 times as likely to report stress. And so I wanted to just share a couple of stories with you what this actually looks like. This is Gerardo, and this is his story, and I will let you read this, but I want to go through a little bit of the physical mistreatment. Many of our participants in the study described physical abuse, and they found that immigration officials were beating them and others with closed fists, with nightsticks, or repeated kicks to the head or rib cage. And in several instances, immigration officials brandished firearms and used handcuffs. In terms of verbal and emotional mistreatment, our respondents described immigration officials' behaviors as rude and arrogant and offensive. And the majority of experience witnessed officials using intimidating language and gestures. And they said that they were spoke to with suspicion and in a confusing manner, and were always seeming to be attempted to being tricked or provoke nervous behavior. And these instances caused emotional distress, including anger, fear, embarrassment, shame, humiliation, and nervousness. Many of the respondents, as I mentioned to you, these are U.S. citizen permanent resident people. They actually can distinguish very clearly the difference between their treatment and those of border crossers or undocumented people. Border crossers were people described witnessing immigration officials trapping and beating and threatening persons they perceived as border crossers, even when these individuals appeared not to resist arrest. In terms of ethno-racial profiling and discretionary stops, our respondents described being randomly stopped, followed on foot, pulled over in personal vehicles or taxis, inspected while in private transportation buses. This is a farm worker community, and so Border Patrol would often load up on these buses and be looking for people as if they were looking for someone in particular. Random citizen inspection often occurred at the U.S. port of entry, where immigration officials do not require probable cause to search property or person. And in some instances, people were stopped just based on their activity or their body language. And so I'll have to stop here, but I wanted to just lastly share the story. I want you to always reframe the idea of border security as a public issue. It's associated with increased stress, and this is occurring not just in Arizona, not just in a state, but all over our country. This is absolutely applicable in lots of different places in our communities. Thank you very much.
Good afternoon, everyone. First, I want to thank all the vested actors who made this opportunity possible and available to engage in this basic democratic discussion about the process of how we solve public problems. This is really unique, and I thank you all for it. As a reformed epidemiologist, I would like to think that I have resolved my own issues about, input obsession with data, and while continuing to play games, such as my oppression is worse than your oppression. But my current passion right now is really using that energy for eradicating prevention deficit disorder, particularly as we talk about public discourse and policies or the lack of policies. So one of the things I always tell my students is, let's think about metacognition. This is your thought experiment for the rest of this afternoon, metacognition. How many have heard this word before? Good. What does it mean? Thinking about thinking while thinking to improve your thinking. That's how we're going to get this work done, folks. Thinking about thinking while thinking to improve our thinking. So my questions for this process are, what are the politics of recognition, and what are the adequate policy responses for eliminating structural violence and promoting health and human rights? I don't know if I have the right button on this thing now, but so when we talk about immigration, one of the things that I want to bring up is this notion about neo-African Americans, social epidemiology, and the progressive obligation to realize health as a human right. Now you may ask, who are neo-African Americans? And they're getting to a slide here for a moment. And what does that have to do with New Mexico? Well, while we're looking for this, you must understand that 80% of this country's history has always been about immigration and citizenship. And that citizenship has always been defined upon sex and gender, and power and privilege in terms of ownership and of property. And so as we move from this, as you can see from this slide here, this is just selected country population ranks of the global African diaspora. And within this slide, what you see here embedded in this is a great deal of cultural and historical trauma. Now, when we talk about immigration, many people, the African Americans or people of African descent are usually left out of that discussion, and that's why it's important to bring this up. And I say this because, as we talk about why this is important to New Mexico, you'll see that we all know that the transatlantic slave trade kidnapped and forced migration for over 3 centuries of Africans and their descendants to the Americas. But since the 70s and the 80s, we've seen voluntary immigration from the former colonized lands of Africa and the Caribbean. And this is now transforming the African American narratives on race and health equity. So that's something that we have to consider as well, too, because some of these folks will identify as black and others will say that they're Hispanic based upon what countries they come from. No matter, you've all heard of the case in Detroit where an Egyptian who's darker than I am was denied access to opportunities because the country tried to tell him that he was not black. They said that you're white based upon OMB Directive 15. And that case is still in court, and that's been going on for several years. But let me get to my second big point really about why this is important. Rethinking global and population health issues is really critical for me because I feel like I'm part of that black international scholar activist tradition of looking at health and human rights and international health, which we have a history of, and it's been overlooked. How many have heard of 2011 iPad? Not the computer. One person has nodded that they've heard of the 2011 iPad. Well, let me tell you what this is. The 2011 iPad is the 2011 International Year for People of African Descent. This was a resolution that was passed by the United Nations, the General Assembly, that says do the following. Reaffirm the Universal Declaration of Human Rights, which means dignity and justice for everyone. It says recall all international covenants on civil and political rights. Recall and affirm all economic, social, and cultural rights. Eliminate all forms of racial discrimination. Eliminate all discrimination against women. Eliminate, stand up for the rights of children, protection of the rights of migrant workers and members of their families, and the rights of persons with disabilities, as well as other relevant international human rights instruments. I don't think it gets any better than this, folks. For me, health is a human right. Education is a human right. And the sooner we get to that and start working with it, the sooner we resolve some of these problems and issues. Now, this convention also, too, as you see, the impact of globalization on communities of color. You see from this map here that, we used to have the old dialogue of the East-West dialogues. Now it's North-South, with all the riches in the Northern Hemisphere and all the poverty in the Southern Hemisphere. And you've got people moving across the equator, moving across that boundary, moving into the cities and creating greatest problems and structures. It's rapidly becoming a problem that we have to deal with. So this issue of migration is something that's very real, that's rooted in neoliberalist politics and education ideology, as well as environmental issues and human rights. So again, why is this important to New Mexico? Well, because of these international issues that I mentioned before, there is a plan of action that's also listed in that declaration that calls for remembering the Vienna Declaration of Program of Action, the Durban Declaration Program of Action, and it says, basically it says that structures matter. And so, as we talk about, I would love to talk more about historical and cultural trauma and trauma-based models, because that's a big part of my research also too. But as you see that, if we put a spotlight on the foreign-born population in Mexico, for those born in Africa, there's been a 77.8% increase of Africans in New Mexico from 2000 to 2011, a 77.8%, and people aren't recognizing that and they're not looking at that. And so these folks are being, because who they look like and what they appear to be, they're tied in with the other issues, and so they become part of that minority within a minority in a minority-majority state, and as a result have their own issues of culture and historical trauma to deal with, and also subjected to unequal distribution of resources, which are necessary for the development of health, wealth, and education. One of the things that I want to get through in terms of one of my pet peeves about dealing with disparities is that I think if we're going to make some action come out of this, that we have to move away from using this term health disparities. We have to start using the term inequities. When we talk about disparities, we're just talking about differential variations. We just continue counting and counting and counting and nothing gets done. Let's start using the term inequities, because there's a sense of justice and morality that's applied to that. There's some active intent to that. The politics of recognition does call for this, social epidemiology, which I've alluded to, the issues of embodiment and the pathways are mapped out there. But at some point, as we talk about public health issues, we've really got to start to talk about the context of the three core public health functions and what those 10 essential services are. And considering that many people do not understand public health in this country or in this state, we've got a problem. Congress put out a report some time ago and basically says that 500,000 people working in public health in the United States, and 56% of them have not been trained in public health, which means they don't understand the theories, the models, the methods, and how to practice. Hopefully, maybe we will get a school of public health in the state sometime soon, but considering that we've heard that Texas has got such bad disparities, and they've got 4 schools of public health, I think we've got to rethink how knowledge is being produced or reproduced in that situation. And I think so at some point we do have to talk about what are the integrative approaches, how we use systems thinking, what is the value of community-based prevention, and that means both reflection and action towards moving towards new synergies for collaboration, how we collaborate across borders, boundaries, disciplines, sectors. And so I'm going to encourage all of us to continue developing the political will to elect political officials who embrace both human rights-based approaches as well as health and all policy approaches. Health and all policy approaches. This is something that was started in alma mater by Ted Kennedy and others in 1978 under Health for All. Basically, health is not just pills and medicines. It's transportation, it's education, it's housing, it's labor, so forth and so on. So, I have to finish. I've just got the sign, and one little last comment. One thing I always tell the medical students: we cannot continue to treat people with pills and medicines and put them back into socially toxic environments. You got a really neat slide here to go. There you go.
Wow, that was an amazing, narrative. Really gave us a quick overview of everything, but I'd like to hear comments from you. You've been here all day. Comments, reflections, questions. I think we have time, Gabe, for maybe a couple. Okay, 10 minutes, great. Over here, first hand. I'm going to bring you the microphone, though.
Well, one of the things that I find so compelling in terms of what's effective and the need for coalition building is the intersections of all of the ethnicities that we've looked at today, and the treatment, historical treatment of these ethnicities. The tactics that are being used are historical tactics. When I think about the woman from Arizona State who spoke second to last, that's what happened during apartheid South Africa. That's what happened in this state during and after slavery. And consequently, and that's what happens right now for African Americans in terms of police brutality. So if we don't coalesce, is that the right word? And connect the historical dots across ethnic boundaries, we're never going to win this fight. And I'd like to talk to you in particular about joining together. We need campaigns. The woman from Tewa International who spoke about this land, and the gentleman from the Congress who spoke about this land and it being indigenous land. Well, in addition to land being what this American system was built on, it was built on land and slave labor. If we don't connect these dots in terms of our messaging and our political strategies, we will never win this fight.
Tell me your name again.
I'm Sunshine.
Thank you, Sunshine. Excellent. Health and all policies, public health, human rights, and working together.
My name is Yolanda Cruz, and I'm with the New Mexico Health Equity Partnership. And I wanted to talk to you a little bit about the policies, and especially like one of the examples I have is the Medicaid policies, and looking at the barriers to people getting approved for Medicaid and how the policies are affecting that. I have a family member who applied for Medicaid and was denied because she would not fill out a voter registration card. And that shouldn't be a reason why you're denied Medicaid if you qualify on every other portion. So she had to go back and forth with them for a while. She was already registered, but what happens to the people who are applying for their children who qualify, but they are not able to be registered voters for whatever reason, whether they are felons, whether they are not US citizens, or whether they just choose not to register. And now you're denying Medicaid to them because they won't fill out a voter registration. And I don't know where that is in policy, but there needs to be, if you talk to people who are having barriers to these things, to applying for benefits and health care, then you'll find out what policies need to be enacted to protect them.
Thank you, Yolanda. Does anyone from the panel want to comment or add anything before we go to our next question or comment? Go ahead, Vickie.
I know just a little bit about this. So I know the voter law did require that registrations be available at public services. So you see registration available usually at WIC or Medicaid or any of these things. So it's the opportunity to. It doesn't sound legal to me. It doesn't sound legal, but I don't know for sure.
One thing that story raises for me, in California, 97% of the people who begin an application for Medicaid never get to a completed application or a decision. 97%. It's a systematic approach to blocking access through bureaucratic excess.
My name is Peace, and I was born in Rwanda. I'm not resident here. I'm not citizen yet in this country, but I will be next year. So my comment is about seeing a doctor when you're immigration. Of course, when I lived in Texas, my Medicaid was cut when I was 18. And then since then, I never be able to go see a doctor. And because my parents won't afford it. So when I moved here, I end up when my blood was really, really low, because I never go see a doctor. So when immigration, children, they don't get to see doctor, they're not healthy because their Medicaid, they're cut off, or even their parents, they're not really educated to to find the ways to take their children to the hospital. I had a Medicare for 18 years, but I had never attended a hospital until I came here. So what was I gonna say is it's good to educate the immigration people when they come to this country that there is so many ways they can live healthily, and to educate the children when they're older, so they're not gonna be sick. Yeah, that's it.
I think I saw one more hand. We have time for one more comment or discussion point. Over here, Veronica, I'm going to bring you the microphone here.
I just want to mention, I completely agree with the comment that Dr. Garcia made in terms of the need for school-based health centers, but I also think that we need to decrease the barriers for Medicaid access and enrollment to children. So have them to be enrolled every year is a barrier. So I would like to present the idea that if the kid is enrolled in school, for all those years that the kid is in school, should not be renewed Medicaid.
Why don't you join me in thanking this awesome panel that closed out our day so beautifully. So with this panel, that concludes the formal agenda for today, which I think was a truly amazing day. As I noted at the very beginning, I think we would all be enlightened and inspired by the end of today. Let's remember, however, that we still have 2 panels tomorrow, so please try to regain your energy. We'll see you tomorrow morning. But remember, I've heard a lot of folks say that one of the most beautiful things of today's events was a lot of opportunities to connect with people you had not met that do similar work across the state. Let's try to continue that conversation this evening. We're at the National Hispanic Cultural Center for the reception. I hope to see many of you there. I heard somebody mention margaritas, so I hope that's what we'll be having over there. So I'll see you over there shortly. We begin at 6 p.m. and that will close out today. Thank you very much.